All right, thank you for the opportunity to present our work. I'm going to be presenting this work entitled Antiretroviral Treatment of Acute HIV Infection and the Prospect for a Functional Cure. So the outline of my talk is going to be why we need a vaccine and cure research despite the fact that we have improved prevention and treatment strategies. And then I'll describe the FRESH cohort, which is a unique cohort to address gaps in HIV prevention, pathogenesis, as well as cure research. And then I'll discuss the impact of antiretroviral treatment during hyperacute HIV infection on virologic and immunologic factors. And then I'll finish by discussing the implications of this work for HIV vaccine and cure research, particularly in resource-limited settings. So I think everybody knows that we have made a lot of progress in terms of strategies for preventing the sexual transmission of HIV, as is illustrated in this particular slide. However, we have significant challenges because none of these strategies, which include behavioral interventions, HIV counseling and testing, treatment of sexually transmitted infections, male circumcision, treatment for prevention, as well as oral pre-exposure prophylaxis, none of these strategies is optimal in the sense that none of them works 100%. And therefore we need new strategies. And we believe that for the setting that we work in a high incidence, high prevalence setting, we need a vaccine in order for us to be able to prevent HIV transmission. Unfortunately, we do not currently have a vaccine that is licensed for prevention of HIV infection. We have also obviously made a lot of progress in terms of treatment with antiretroviral drugs. Unfortunately, there is still significant morbidity that is associated with even with the use of antiretroviral therapies. For example, we know that cardiovascular disease, metabolic disorders, neurocognitive abnormalities, liver disease, and the list is very long. But all these abnormalities continue to persist, and they are more common in HIV-infected people, even when they are fully suppressed with antiretroviral therapy. And people who are HIV infected and on antiretroviral therapy also have reduced life expectancy, even in developed countries. So in order for us to really make a significant dent on the HIV epidemic, we believe that it is going to be very important for us to either develop an effective vaccine or develop a cure for HIV. I think everybody in the room will probably be aware that there are significant barriers to an HIV cure. And this is because although HIV can be suppressed by antiretroviral therapy very quickly, and the viral load remains undetectable for as long as the individual is using antiretroviral therapy, as soon as they stop using antiretroviral therapy, the virus rebounds almost to the same level as it was before the initiation of antiretroviral treatment. And the reasons for this are many, but they include the fact that we have latently infected CD8 T cells. We have incomplete suppression of virus replication such that even on antiretroviral therapy there is ongoing low-level replication. And we also have anatomical reservoirs where the antiretroviral drugs may not reach efficiently, such as the central nervous system, the gut, as well as the reproductive tract. So some of the strategies that have been suggested to overcome these challenges and to achieve at least a functional cure include the elimination of latently infected cells. And this can be done through ablative chemotherapy, shock and kill strategies. Cells can also be engineered to become refractory to HIV infection. And then finally, optimization of antiretroviral therapy has also been suggested as a way to achieve a functional cure of HIV infection. And in particular, early treatment of HIV infection or intensification of treatment has been shown in a number of studies to be successful in at least achieving long-term remission of HIV in people who are infected. And we believe that this is a strategy that we could at least try in a resource-limited setting because it has the capability to not only to inform us about what goes on in terms of reservoir establishment, but it's also a strategy that might have potential for use in resource-limited settings. So this is a strategy that I'm going to be discussing, and this is a strategy that we have attempted in South Africa. So in acute HIV infection, the questions that we've been asking is what lessons can we learn from acute HIV infection? And we know that when somebody gets HIV infected, there is uncontrolled virus replication to a peak viremia, and then the viral load comes down to what we call a viral set point. And we know that the viral set point is a predictor for the rate of disease progression as well as the risk of transmission. And we have been interested in particular what is happening in the earliest stages of HIV infection in the FIBIC1 and FIBIC2 before immune responses, antiviral immune responses, at least adaptive immune responses can be detected, versus what happens thereafter when immune responses become established. And in particular, I've been interested in asking what happens if you initiate antiretroviral treatment very, very early during FIBIC stages 1 and 2 versus initiating antiretroviral treatment during FIBIC stages 3 and 4 and onwards when adaptive immune responses become established. And some of the key questions that we're interested in answering are, what are the characteristics of the transmitted founder virus? What are the immune responses in acute infection, and why do they fail to control the virus ultimately? And what is the impact of the transmitter founder virus on these immune responses? What is the impact on the reservoir? And what is the impact of viral treatment? And then finally, what we would like to, ultimately the goal of this research is to see whether we can mimic effective immune responses or augment ineffective immune responses so that we are able to either achieve an effective vaccine that will prevent HIV infection or achieve a functional cure. So in order to do this, we thought that we could take advantage of the fact that we have very high incidence of HIV infection in South Africa by establishing an acute infection cohort, which we call the FRESH study. FRESH stands for Females Rising Through Education, Support and Health. In this study, we recruit women who are between the ages of 23 and 23 years old who are at high risk of HIV infection. This is from our own surveys where we have shown previously that women in this age group are at very high risk of HIV infection. We provide them with an intensive empowerment program, life skills and job readiness curriculum that coincide with sample collection. We test these individuals twice weekly for 9 months, and by testing them twice a week, we are able to, when they come for these empowerment classes, we are able to identify individuals at the very earliest stages of HIV infection. And we can also collect pre-infection and post-infection samples, including blood, female genital tract samples, as well as lymph nodes. And then we can study host and viral factors associated with acquisition and disease progression, including some of the ones that I've mentioned, such as the transmitted founder virus, and as well as antiviral immune responses. So far, in this study, as of March 15, we had recruited 52 individuals with acute HIV infection. 14 of the first individuals that we identified were not treated. 11 of them were identified in FIBIC stage 1. 38 have since been initiated on treatment as soon as they are detected with acute HIV infection. 85% of them are in FIBIC stage 1. The incidence in this cohort, which underscores the point that I made in the beginning of my talk about the very high incidence of HIV infection in this setting, the incidence is 8.5, and this is in the era of antiretroviral therapy, which is still very, very high. Majority of the individuals we have identified with acute HIV infection are identified within six months of entering into our empowerment program. So typically, this is the kind of data that we are able to get on these individuals. And here I show you the first individual we identified. Again, you can see that they were sampled a couple of times before they suddenly became HIV infected by detection of HIV RNA in their blood. And you can see that the viral load then goes up to a peak and then comes down to what we call a viral load set point and stabilizes. At the same time, because we have pre-infection samples, you can see that the CD4 cell counts drop precipitously when this individual gets infected, and then there is a recovery in terms of the CD4 cell count, and then the infection proceeds. In contrast, we have this individual who was treated during acute HIV infection. You can see that we identified this individual very, very early during HIV infection. We were able to blunt peak viremia such that the peak viremia did not exceed 100,000 copies, and then the individual was completely suppressed by about a month or so post-infection. You can also see that we were able to preserve CD4 cell count in this particular individual. And when we aggregate all the data together, you see that early treatment blunts peak viremia in particularly in FEB1 treated individuals compared to individuals that were not treated who had much higher viremia. And you can also see that early treatment in FEB stage 1 preserves CD4 cell count. So we think that by early treatment we are preserving immune responses or some aspects of the immune responses in these individuals. We have then subsequently looked at humoral immune responses as well as CD8 T-cell immune responses in these individuals. And here I show you the evolution of humoral immune responses in participants. The first 14 participants, as I mentioned, were not treated, and you can see that all of them seroconverted by Western blot, whereas the individuals that were treated early were heterogeneous in terms of their seroconversion, where the blue dots represent a Western blot negative result, whereas the red dots represent a positive result, and the open circles represent an indeterminate result. Most of the individuals that were initiated on treatment early and actually seroconverted were individuals that we did not pick up at FEB stage 1. In other words, these individuals most of them were past peak viremia already by the time that we initiated treatment, and therefore you can see that subsequently they became Western blot positive. Like I said, we have looked at CD8 T-cell immune responses in these individuals, and we see some heterogeneity in terms of the ability of these individuals who are initiated on early antiretroviral therapy to make CD8 T-cell immune responses. We have looked at CD8 T-cell immune responses using tetramer staining, which is a very sensitive way of looking at the ability to detect CD8 T-cell immune responses. So in this particular individual who was treated very early, you can see that their peak viremia did not exceed 1,000 copies per ml. This individual did not seroconvert by Western blot and by most of the other assays that we did, and we could not detect any tetramer HIV-specific responses in this individual up to 1 year post-infection. In contrast, we have this individual who was treated in FEB stage 5. This individual seroconverted, as you can see, by Western blot, although they were indeterminate at some point. This individual, despite suppressing viremia completely in a very short space of time, you can see that this individual generates tetramer-specific, HIV-specific responses. And these are responses that we're able to detect up to 1 year post-infection. In fact, over time, they seem to be generating responses that seem to expand over time. So there is a lot of heterogeneity in terms of the CD8 T-cell immune responses that these individuals make. We have looked at the quality of these CD8 T-cell responses, and what we had shown in a paper that is already published earlier, about a year or two ago in Immunity, we showed that these individuals who are not treated during acute HIV infection, so the untreated individuals, have CD8 T cells that are defective in terms of cytokine secretion. As you can see here, as assessed by the ability of CD8 T cells to secrete interferon gamma, you can see that these HIV-specific CD8 T cells produce much less interferon gamma compared to CMV-specific CD8 T cell responses in the same individuals, suggesting that in acute HIV infection, CD8 T cells are defective in producing key cytokines. And it is not just in cytokine production. When we look at CD127, which we use as a marker of long-term memory in these individuals, again, you can see that HIV-specific CD8 T cells have much less expression of CD127 compared to CMV-specific or EBV-specific or even flu-specific CD8 T cells in the same individuals, again suggesting that these individuals in untreated HIV infection are defective. If you contrast that with the HIV-specific CD8 T cells in the treated individuals, in the individuals in whom we could detect HIV-specific CD8 T cell responses, what you see is that early treatment somehow seems to restore some of the function. And here I am looking at interferon gamma secretion in CD8 T cell responses in early treated individuals, and that is in contrast to this untreated individual with the CD8 T cell immune responses, where you can see that the production of interferon gamma is much less compared to the individual who was treated early during acute HIV infection. And this is the overall data where we have shown that early treatment restores the function or some of the functions of CD8 T-cell immune responses compared to untreated individuals. We have also looked at not just the secretion of key antiviral cytokines, interferon gamma, but also, again, looking at the frequency. We see that in treated individuals, they have much lower frequency of CD8 T-cell responses, and I think this is to be expected because obviously we are interfering with the antigen load very, very early on, and so they have much less frequency of tetramer-specific CD8 T cells compared to the untreated individuals. But these immune responses, CD8 T cells, even though they are of lower frequency and magnitude, they upregulate molecules associated with long-term survival, again suggesting that by treating early, these CD8 T cell responses may be of higher quality than in the untreated individuals. So that is looking at the immune responses in these individuals. The other aspect that we have been interested in is looking at the nature of the transmitted founder virus in these individuals. And we know from historical studies that HIV transmission is characterized by a genetic bottleneck, such that only a few variants establish infection. And understanding the characteristics of the transmitter founder virus may hold the key to novel prevention strategies. So here, we specifically investigated the ability of broadly neutralizing monoclonal antibodies that are likely to enter clinical trials in the next 2 to 3 years, and the ability of these monoclonal antibodies to neutralize these transmitter founder virus envelopes from the fresh cohort. So just to review the known broadly neutralizing antibody epitopes on the HIV envelope, there are some that target the V1, V2 glycan, and there are many of them. So among these antibodies, we tested the PGD 1400. And then we also tested PGT151, which targets the GP120, GP41 interface. We tested PG121, which is binds to the V3 dependent glycan. And then we tested VRC01, which is actually entering clinical trials in South Africa. And then we also tested the 10E8 monoclonal antibody in a few of these transmitter founder virus envelopes. And the method that we used in order to do this neutralization assays was by pseudotyping these transmitter founder envelopes in TZMBL assay. And as you can see, we see that these monoclonal antibodies actually vary significantly in terms of their ability to neutralize these transmitter founder viruses. So for example, the VRC01, which is the one that is entering the clinical trials in South Africa, was not able to neutralize most of the transmitter founder viruses that we have analyzed so far, whereas PGT151, PGDM1400, as well as PGT121 were quite broad in terms of their ability to neutralize the transmitter founder viruses. And these are representative neutralization curves of the data that I have shown you. Again, showing you that monoclonal antibodies, PGT121, 151, as well as PGDM1400 require much lower concentrations of these monoclonal antibodies were required for the neutralization of the transmitter founder viruses compared to VRC01, which is the monoclonal antibody that is now entering clinical trials in South Africa. And I think this data underscores the need to understand the characteristics of this transmitter founder virus and of different agents, biologics that are going to be used in a setting like South Africa in terms of the ability of these biologics or monoclonal antibodies to inhibit these transmitter founder viruses so as to guide the selection of the candidate biologics or antibodies that are likely to have the greatest effect in terms of preventing HIV transmission. We have also been looking at the reservoir establishment in these individuals, And when we started this study, we thought that perhaps by starting treatment very, very early during Phoebic stage 1, we might interfere with the establishment of the reservoir. But actually what we find is that the reservoir is established very, very early. And here what I'm showing you is total DNA measurements shown here in black and viral load in this individual who was treated during acute HIV infection. And you can see that the viral load got completely suppressed within 30 days. There's a very slow decay of the total DNA in this individual, but you can still detect it by 1 year post-infection. And this is in contrast to a chronically infected individual where you see that the total DNA during acute HIV infection is as high as during chronic HIV infection, if not higher. There is a decay, significant decay, but it is still detectable by 1 year post-infection. We can show from the few samples that we have analyzed that the total DNA at detection correlates with the viral load. So contemporaneous viral load is a significant determinant of the total DNA. And again, like I said, if you look over time, you see that there is a decay of the viral reservoir, but it is still detectable by 52 weeks post-infection. And in almost all the patients we have looked at, even those that were initiated on treatment during Phoebic stage 1, you can still detect some level of the DNA by 52 weeks post-infection, which suggests that if we were to interrupt treatment in these individuals, the virus is still likely to rebound, even though the total DNA is certainly much lower than in chronically untreated individuals. So one of the other things with regard to the reservoir that we have been interested is looking to see where the virus is actually contained, because we cannot detect virus in these early treated individuals in peripheral blood, but we have been able now to obtain lymph node excisions from some of these individuals, and we can begin to look to see whether we can detect any virus within the lymph node tissues. And here I'm showing you a lymph node that we have done some immunohistochemistry staining on. And in this particular lymph node, we used BCL6 to capture the CD8 T cell follicles within the lymph node. And you can see that there is a clearly well-defined B cell follicle as identified by BCL6 in this individual. And if you look at where the P24 staining is, it almost always overlays with where the B cell follicle is in this individual. So we can see that there is high levels of P24 within the B cell follicles in these individuals, particularly whether in fact they are suppressed or not. So this is an individual that we treated early, and once again you can still detect P24 staining. You can see that most of the P24 staining is within areas within the B cell follicle. So in conclusion, we have been able to identify acute HIV infections in high incidence setting. We think that acute HIV infections might offer novel insights into the characteristics of the transmitter founder virus, the immune responses, and reservoir establishment mechanisms. And this knowledge could be important for both the vaccine and the functional cure strategies. The fresh participants initiated on antiretroviral therapy may have higher quality cytotoxic T cell immune responses, but the reservoir is established very early and decays very, very slowly, which is likely to be a big challenge for achieving functional cure, even though by starting antiretroviral therapy during very, very early stages, it might be a little easier to achieve a functional cure in these individuals. We think that understanding of immune responses and reservoirs following antiretroviral therapy initiation may be useful for future intervention studies. And we think that this cohort is an ideal platform for future interventions aimed at cure, and we are currently exploring the possibility of vaccinating these individuals with a mosaic adeno26 DNA and and perhaps with a passive immunization with a monoclonal antibody to see whether we can, if we then subsequently interrupt, we might be able to achieve functional cure in these individuals. So I'd like to acknowledge my colleagues and collaborators, Krista Dong and Emba Mudle, who are responsible for recruiting these participants. Zazan Dlovu, Bongiwe Dlovu, as well as Kavitha Reddy have done most of the immunological and virological work that I have shown today. And we are a large group of people that I would like to acknowledge. Also the study participants. We collaborate with Bruce Walker at Harvard Medical School, and Doug Kwon and Musi Gabriel Michael is the biostatistician. And we have received funding for this work from the Bill and Melinda Gates Foundation, from IAVI, from the National Institutes of Health, from the South African DST, the HHMI, and more recently from Gilead Sciences. So thank you very much, and thank you for the opportunity once again to present our work. Thank you.